Well, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, colonoscopy is something most of us do in general practice, and we rely on our nurses and our nursing assistants and our endoscopic assistants to help us perform our colonoscopy in an expedient way and successful way, and in particular getting to the cecum is part of that, and if not absolutely part of that. And where we go on telling our assistants when we encounter loops is really the focus of today's discussion. So when I was starting back in the early 80s, and we asked for a lift as we realized that we weren't getting a one-to-one transition as we move forward with the endoscope, the nurse assistant would push in the sigmoid colon left side of the patient and push over. And how naive were we at the time, but realized that's not the best approach. So the science of liftology is what I want to just spend a minute or two with you here and talk about. Where do you tell the nurses and the assistants to push? And kudos to Dr. Doug Rex, the master of colonoscopy and my era, and certainly as it relates to education in this area. And Doug's built on some great points going forward. I'd like to amplify this a little bit with some insight from what I do. So let's start with lift number one. Lift number one comes with, you have that early transition of the sigmoid loop, not starting now in pushing from the left pelvis, but pushing from the right side, the right side down. And particularly when I ask for a sigmoid lift or a right side down lift, I tell them this is a pressure down towards the left pelvis and the left iliac crest. It can be done with an open hand. I tell the nurses I want a two-hand lift generally for most of these things. I don't want you generally to push in with a fist, but I really want your fingers splayed out, and particularly to blunt that first transition of the transition as it goes around the first sigmoid turn. When I get beyond the sigmoid colon, and I try and make that transition with minimal error, if any error, if I can, if I'm having any type of a redundant colon, it's water, 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 and this is to flush your way through rather than distend the colon and make it more angulated as you start to put air in. Doug has taught us all that water installation is certainly a good way to allow not only to keep the looping and minimal, but the water nicely distends the colon in a straighter fashion. So water, water, water as you go through that area. Second lift, splenic flexure. So splenic flexure lift, in generally the nurses or the assistants on the left side of the patient, we have them push across as you try to transition into the transverse colon. Third lift is typically a transverse colon lift if you think that you're getting now a loop in the colon, and particularly we see as it dives into the pelvis. So I'll have the nurse or assistant push up if they can from the left side of the patient. Traditionally that's where they are, or if they're able to do a V lift going up, and if they're not, and some of these patients are fairly higher BMI, I'll have them come across and reach with their arm across it, I'll say, and I lift it across the umbilicus. That'll help transition and potentially give you that same transverse colon lift. Sometimes we'll need two assistants, and generally to push from the right side and also push from the left side. So again, splitting up on that transverse colon. Fourth lift is at the hepatic flexure, which is typically when I'm trying to dive down into the ascending colon. If I still have a question about getting down into the cecum, I'll have them push from now the right side higher up, subcostal, and going down further down towards the left pelvis at more angulation in the first lift. And sometimes if that doesn't work, then I'll have them reach all the way across, typically easier from the left side where you're pushing up at the very deep in the left lower quadrant, or reaching across in the left lower quadrant and pulling again up. That's true sigmoid. That bend at the lower sigmoid is the fifth lift that I will traditionally do. I virtually never reposition the patient anymore, and sometimes we would do this as we tried to drop into in the posterior position on the recumbent position for the patient, drop into the cecum. Particularly the aspiration risk, I think, is accelerated, so we most always can get there with any type of lift. The other caveat I would make is before you make this lift and pull back, let go of the lift before you pull back. Another point is the lifts only work for a short period of time in your transition, so you don't forget your endoscopist or your nurse. They are sometimes left hanging, and generally 20, 30 seconds you get where you get your one-to-one transition, and then you can let them go and potentially pull back and again, reconfigure if you need further lifts, but don't leave your nurse and assistant out there hanging. It doesn't take that long to affect the lift, but again, let the lift go before you pull back. The final point I'd make is use the lifts before you get the loop. So again, if you're finding looping, pull back, reduce the loop, and then use your lift. So liftology, if you will, is something that we were never really taught, at least I wasn't in my early career as a gastroenterologist, and it's something that more and more, I think, a little bit of time with your nurses and nursing assistants, as they may be somewhat naive. Don't tell them, I need a lift. Tell them where you need the lift, and I think you'll find the transition, you'll find that you'll guide your assistants and glide to the cecum with greater facility and hopefully expediency. I'm Dr. David Johnson. Thanks again for listening.